So today we're going to be talking about why we see and why we don't. So fairly informal. If you guys have questions, we'll have a ton of question time at the end. We can also have some questions during it if you have something specific relating to what we're talking about. So first off, let's talk about why we see. So we're going to go a little bit over what the parts of the eye. So you can envision that the eye is basically a camera. So you have the eye is the camera that gives you that sense of vision. So do I have a pointer up here at all? Do I have a pointer?
There you go. You can see that.
Okay. So I guess we'll go like this. Okay. So the front of the eye is called the cornea. So the cornea is basically where light first penetrates in. And the entire purpose of the eye is to take the light rays that come in parallel from the sun and focus them into a sharp point onto the retina. So in order to do that, there's the pointer again, they have to go through the cornea, through the front of the eye called the anterior chamber, the aqueous humor, goes through the pupil. The pupil is actually not really a structure. The pupil is where the iris isn't. The iris is the pretty colored part of the eye. So the pupil is where the iris isn't. It looks black because there's no light in the back of the eye. Light goes in, not coming out. So the pupil appears black. It's actually just a hole. So light goes through that hole, through the lens, which is an important structure we'll talk about in a little bit, through this big cavity here called the vitreous cavity, the posterior chamber, the vitreous, and it hits the back of the eye. Now the back of the eye, what lines the back of the eye, is called the retina. Oh, there we go. So like I said, the entire purpose is to take those light rays and focus them onto a sharp point on the retina. The retina is actually the film of your camera. So you can envision the whole front part of the eye, the cornea and the lens. Those are the lenses of the eye, of the camera. So, you have your nice SLR camera, your Canon Rebel. You take this lens off, you put that lens on, all of that stuff. All that does is focus that light into the back of the eye. The retina is where the light is actually changed into a chemical signal. You have the little photoreceptors, which similar to if you're doing solar energy, or you have those solar plates, and those solar cells actually take the energy and convert it into electrical signal. Exact same thing here. You have the light rays that then stimulate those rods and cones in the retina. Those undergo a configuration change, send the signal to the nerve, the optic nerve over here. The optic nerve is, imagine that once you have your camera, you plug that camera into the computer. It downloads all that information into the computer. The computer is actually your brain, specifically in the back of the brain, the occipital cortex. So this whole thing is very similar to a camera. You've got the lens, you've got the film, which is the retina, you've got the cable connecting to the computer, the cable is the optic nerve, and then you have the computer, which is your brain. This whole thing works together to make this amazing thing we call sight, and specifically, spectacularly detailed sight. Now that sight happens because these cells, these photoreceptors, are packed really closely. You have the cones that are the color in the center part, so that's in the macula. So if everyone goes about like this, that's your macula. So this is the majority of your vision, that section of the eye. That's where those photoreceptors are most densely concentrated. A lot of them are cones. This is why when it's bright light, everyone sees really well and everything sees in color. This beautiful section of the eye called the macula, we'll talk a little bit more about the macula because it goes bad, as we know, in macular degeneration. This macula is right here in this section, the greatest density of photoreceptors, and specifically, again, color photoreceptors or cones. One of the reasons things aren't quite as sharp and a little bit blurry in dim light is because the rods, which are the black-white, those are positioned a little bit further away outside of the macula, and their concentration, their density isn't as thick. So the ability to differentiate small, fine details, et cetera, those are actually, it's not as concentrated, so the resolution is not as good. It's going from, the 18 megapixel retina or macula to like the 5 megapixel periphery. So you can envision the graininess of that pattern that you see. So once the light actually, once that signal hits the optic nerve, it starts traveling back into the brain. Now this is a really important thing. So when we talk about lefts and rights of the world, we're talking about lefts and rights of both eyes. So when you have a stroke, for example, you don't lose vision in one eye unless you have a stroke of the eye. I'm not, caveat to that. But when you have a stroke in the brain that has a visual field loss, it's half of each eye. So you can envision this as a line there. Half of each eye is lost because when those pathways come, they actually crisscross at a place called the chiasm. And then half of it goes back. So the left side of the brain sees the right side of the world. The right side of the brain sees the left side of the world. We all know that the left side of the brain does the right arm and vice versa, right? Yes, good. Okay. Thank you. So you can have this nice picture of where the oranges and the purples are in this, that there's this little crossing over, and those fibers actually go back to the brain, and then again, that brain is where that's all interpreted. So, quick view of how sight works. So, question is now why we don't. Now, this is the more interesting part. Why don't we see? So, basically, the reason we don't see is because that whole visual axis was interrupted somewhere. Now, as we know, there are so many different parts of the human body. There are so many different ways that the body works. I mean, honestly, from every cell to every protein to large organs, the whole 9 yards from top to bottom, beginning to end, there are so many ways the system works, and there's a disease for every single one of them that breaks. So in all of these things, there's a disease for why it breaks. Now, that's why we have all these fun names and why doctors have all these subspecialties, is because the body can break in so many ways, it's mind-boggling. Similar to vision loss, well, you can actually have vision loss in any pathway of it. You can have vision loss in the cornea. You can have vision loss because of the lens. As we all know, we'll talk about cataracts. Something wrong in the vitreous. Diabetics have vitreous hemorrhages, and the vitreous gets clouded. There are tons and tons of reasons why the retina has problems. The optic nerve. You can have strokes as there's tumors that compress that chiasm, specifically pituitary tumors are the most common one, but there are others. You can have strokes or tumors that hit any of those radiations as those fibers from that chiasm go back into the brain, and then you can have strokes or tumors or injuries to the brain. Any part of that pathway can result in vision loss. So we're just going to talk about a few of them. These are the top 5, well, top 4, and then we'll have an other category where I'll kind of open it up to questions if you have any questions about specific other things you'd like to talk about. But these big 4 are the majority of why, probably that's about 75% of my practice right there. Well, actually, that's not true. Refractive error, really, I don't do very much. Most of the refractive error is done by optometrists. And this refractive error is fantastic. It's a really easy one to fix. So you just need a pair of glasses. So refractive error is actually the #1 leading cause of vision loss worldwide. Not blindness, but vision loss. 275 million people are visually impaired because they just need a pair of glasses. So talk about the easy stuff. So myopia, nearsightedness. This is the most common one. Most people in the United States and actually in the developing world are nearsighted. Lots of reasons and thoughts behind why it is we're having an increased frequency of myopia throughout the population. But basically, the eye is too long or the magnifier is too strong, so that the light rays are actually, their best point of focus is in front of the retina. So what the glasses do, and you can see myopic lenses are thicker on the sides, because what they're doing is they're spreading the light out so that then it goes back in. So this is the #1 cause. The nice for people who are myopic, who are nearsighted, because you can just take them off and you can see up close. Or some people are really nearsighted. My husband's about a -8.5. And he'll take a splinter out like this without his contacts in. He loves it. Usually. But however, it's one of those things you wake up in the morning, there's the glasses to walk to the bathroom. So the contrast of that is hyperopia. Hyperopia is basically the other side of it. So the eye either doesn't focus it strong enough or the eye is too short. Oftentimes it's the eye length. We call it axial myopia or axial hyperopia. Sometimes the cornea is a little bit different. The lens usually does not cause this. You can imagine that if you have a really steep cornea, it's going to focus it really tight, or if you have a really flat cornea, it's not going to focus it as much. Same with the distance, the length of the eye. All of these are fixed with glasses, contact lenses. Incidentally, this is where LASIK works as well. LASIK, or PRK, or any of the corneal refractive surgeries, they all work on the cornea. So what they're doing is they're changing the shape of the cornea, making those little edits to the glasses requirement by changing the shape of the cornea and bending the light on that side, because it's a lot easier than going in, has a lot fewer internal eye side effects than doing a cataract surgery in a 20-year-old and make them all of a sudden in reading glasses. So the other thing, I'm going to give you a little video here.
The shape of the cornea is spherical, like a ball.
Maybe.
This allows light to pass through the lens without
I
distortion.
don't have sound on my video.
Focus properly on your retina to provide a sharp image of what you're seeing.
Aha.
Astigmatism,
Ooh, that was loud.
the cornea is misshapen and has more of an oblong shape, like an oval, causing light to bend and distort as it passes through the lens. This makes provide clear vision.
All right.
Your
You know what? I'm going to ditch this thing because honestly,
of your cataract
No.
surgery by choosing the Acrosoft IQ.
All right, let's try this one again.
With a healthy normal eye, the shape of the cornea is spherical, like a ball. This allows light to pass through the lens without distortion. Light rays focus properly on your retina to provide a sharp image of what you're seeing. With astigmatism, the cornea is misshapen and has more of an oblong shape, like an oval, causing light to bend and distort as it passes through the lens. This makes objects appear blurry or unfocused at all distances because light rays are not focused on one spot to provide clear vision. Your astigmatism can be addressed at the time of your cataract surgery by choosing the Acrosoft IQ Toric IOL. Unlike a basic lens, which will correct your vision at one
Remember this,
distance,
we're going to refer
the
back to this
Acrosoft
part.
IQ Toric lens also corrects astigmatism by minimizing the effect of the misshapen cornea, allowing the light rays to arrive at one single point on the retina, providing you with clear, crisp distance vision, usually without the need for glasses.
All right. You really want me to worse? Yeah. Okay. Okay. I can project my voice. I'm pretty loud. Okay, I'll keep it on. So some of the stuff I'm going to do in this talk is going to be, last year we talked very similar things: cataract, glaucoma, macular degeneration. This is the majority of what a lot of people want to know about. This year I'm going to take that, I'm going to talk about it, and then I'm going to tell you a couple really, really interesting new things that are going on in the fields of each of these, which I'm really excited to say are now actually available in Fairbanks. I hate the idea of just because we're in Fairbanks means we don't have access to the latest and greatest and the best of the best, and that's just not okay. And so I've spent a lot of time in the past year getting us, keeping us up to the next level of eye care. That technology, you got to overcome all the hurdles to get it. And so I'm going to tell you about some of the new technologies that are now available, that are available to everybody, and yes, to us as well, even in Fairbanks, Alaska. So let's talk a little bit about cataracts. So what is a cataract? So a cataract basically is a clouding of the lens. We talked about the lens here. So the lens, as we age in this joyous aging process that we are all going through, all of us at different stages, our body changes. I'm sure you guys have realized this. And so one of the ways that our body changes is that lens becomes harder. It becomes yellow. It is not as distensible. So when this is an important thing, because we talk about this joyous thing called presbyopia, this arm's not quite too long to be able to see anymore. My 6-year-old daughter, she can take something and she can look at it right here and at distance. I mean, she has no problems whatsoever. She can read a book right there in front of her face because her ability to change the shape of her lens is spectacular because she's 6. So my mother, who's about to turn 70, she pretty much has no ability to do that at all, because by 70, I've lost all of that ability. There's no more mobility of that lens itself to change shape. It's gotten hard. The fibers have gotten a little weak, similar to all the rest of our fibers in our bodies. Those fibers that change things have become lax. So all of that leads to this thing called presbyopia. So me, at my really young age, are not quite there yet, but you can see sometime in the 40s you start. I've noticed my husband, who's 48, I've found my reading glasses just sporadically placed about the house now. He won't ever be caught wearing them, but they're there because this is a normal process. So most of that happens in this cataract here. So what causes cataracts? Well, basically the protein clumps in the eye, it actually is a configuration change. The proteins actually change shape. And as a result, they clump together, they turn yellow, et cetera, et cetera. The rate of this is an aging process. Now, aging speeds up sometimes with other conditions. Diabetes is a big one. Smoking, how well you care for your body. If you don't care as well, all of that aging stuff speeds up. Radiation, if you've ever had radiation exposures of any kind, the lens is like a sponge for radiation, rapidly causes cataracts. Steroid use, topical, oral, inhaled, that will also increase the speed of cataracts. I'm going to talk about three main different types of cataracts. This is a nuclear sclerosis. The nuclear sclerosis, this is an age-related hard cataract. The lens turns very yellow. Surprisingly, people are very slowly symptomatic with this because it changes so slowly over time that people don't notice. It's like watching your children grow. Like, I can't tell the difference. My mom comes to visit every 3 months. Oh my goodness, you've gotten so big. Same concept. It changes so slowly over time, you never actually notice it. A cortical cataract is actually faster growing, becomes very, very glary. People notice this a lot up here because of our extremities of light. All winter, our pupils are dilated because it's night out, light hits it from the headlights, or wherever you see these giant glares, these halos, those headlights, instead of being headlights, become headlights. That's a lot of cortical. The others will do this as well, but corticals are one of the classic ones for this. Most people are combined. You know, people have multiple different versions. This one you can see in the back of it is called a posterior subcapsular, very fast growing. This is the one that my vision has decreased, over the past weeks to months. That's a posterior subcapsular cataract. So talk a little bit about the symptoms. Basically, cloudy and blurry vision, those are the mainstays. Your vision's just not quite as good as you'd like it to be. Glare is one of the biggest ones we have up here because of our extremities to light. Pupils dilated during the wintertime, the sun right off the horizon all summer long, very, very bright. Glare is the number one reason I take cataracts up here out, especially in headlights. There's usually a bump of people coming in because in October, all of a sudden you're started driving at night again, and wow, those headlights are a lot bigger than I remember them being. That's cataracts. Colors are faded. Now again, this happens really slowly, and that's the biggest one that you see in the nuclear sclerotic because everything turns yellow. You don't realize this until you take a cataract out and people say, holy cow, I had no idea. Look how white that is. Look how blue this is. The sky's blue. I thought it was green. When you take those out, you have no idea how far you can go down that line until you remove the cataract. And it's really quite spectacular what you can see when people are able to take that filter out, that light filter. Difficulty seeing in night vision, again, the same idea. So you basically have a yellow thing, light can't penetrate through it, so it gets attenuated. You take it out, and everything's brighter. Single-eye double vision. It's a really important distinction. Do not think that both-eye double vision is cataracts. When I talk about double vision like this is you cover one eye, you see two images. You cover one eye, you see two images. If at any point in time you see two images, you cover one eye and you only see one with either eye, all bets are off. You need to come see me. That is not a cataract. That's something wrong with the alignment of your eyes. It needs to be seen immediately. So that is not the double vision we're talking about. The double vision in cataract surgery is usually a shadow image. So that's an important distinction. So please, if anyone ever says, yeah, I have double vision, make sure that if they actually, does it go away when you cover one eye? Yeah, it does. Then they come see me directly because that's an important thing. Very important. Frequent glasses changes. So basically, one of the things that happens with the cataract forms is the actual refractive index. That means how much does that material bend light? That actually changes. And so oftentimes people become increasingly nearsighted. We call it a myopic shift. So they become increasingly nearsighted as that light is bent steeper and steeper and steeper through that lens because the actual lens material has a configuration change. It's actually changing its shape. So those are examples of what a normal vision versus what cataracts. So the question of when to treat. So basically, it's an easy answer. This is a risk-benefit ratio. The state of Alaska has that if it bothers you enough, it affects your activities of daily living. If it bothers you enough, take the cataract out. This is a really good surgery, and I have a couple videos, and all my videos, the videos that I'm going to show, the majority of them here, they're the professional videos. You'll see my personal homemade video. I'm a much better surgeon than I am a graphic video designer. So I'm going to let the professionals do that. So you're going to see it comes at the price of their patient education videos from the companies that I've deemed good enough that actually that's what the product that I use. So you'll see those, but they're way more educational than the ones that I can come up with. So the time to do surgery is when getting rid of those symptoms is worth a small 10-minute surgery, low risk, very reproducible. It's an excellent, very, very, very mature surgery. In the world of surgeries, this is probably one of the most mature surgeries. When getting rid of those symptoms is worth the risk inherent. It's cost-benefit ratio. And as soon as you cross that you're willing to do it, that's when you take it out. Not when a doctor tells you to. It doesn't need to ripen anymore. It's when it bothers you enough to warrant doing the surgery, period.
I thought last year you said you could only do it one time too.
One time per eye per lifetime.
Yes.
Yep. Once you take the lens out, it's like an appendix. You take it out, it's gone. It's an actual anatomic entity. So you take it out, you put a new one in, it doesn't grow back. So you can get some scar tissue that forms behind it that needs to be treated with a laser. They used to be called a secondary cataract because a lot of the symptoms are similar, but that's a 30-second laser, not the same as cataract. Little video on cataracts.
During cataract surgery, your ophthalmologist will make a small opening in the side of your cornea. He or she will insert a pen-shaped instrument through the opening to reach the lens. This instrument uses a special type of energy to break up the center of the cloudy lens.
Ultrasound energy.
Then it will carefully suction out the lens pieces. Your surgeon will then insert an artificial lens called an intraocular lens, or IOL. This IOL will stay in your eye permanently. The new lens lets light pass through and focus properly on the retina, bringing back clear vision.
Great. So, yes?
You say you can only do it once, but other than cleaning up the fogginess with a laser, why would you need to do it again? I mean,
You don't.
A lens.
Yeah. No, you don't.
It's not like you can do it too early.
Well, I mean, to some degree. I mean, at my age right now, I would never take a cataract out. So, my cataract is so minimal, it's barely even called that. But, anytime you do anything, there's going to be a risk associated with it. It's a surgery. There's a very, very, very small risk of bad things happening, just like any other surgery. I mean, get in your car, you drive across town. Have people gotten in horrible car accidents driving across town? Yeah, that's happened. The benefit of getting where you're going in a timely manner, no, that's worth that risk associated with it. So most of us on a daily basis get in our car and drive across town. That said, when the risk is to the point where you wonder, do I really need to do this? Now, obviously, if you don't need to do this, if you have no symptoms whatsoever, if there's no benefit, then why take any risk at all? So, the time to do it is when you want to. You don't need to wait until you're way down the line. You don't need to wait until it's really awful because the surgery is so low risk, there's no point in it. But, some people have different thresholds of having any kind of procedure done.
Well, the new lens is not going to be as good as the old God-given lens when it's perfect. It's not going to be flexible, for instance. You won't be able to focus with that.
Most people, yeah. Most people, by the time they get a cataract, they've already lost that distensibility.
Right,
So, yes.
let's say, why would you get a cataract surgery when you're 20? No.
Exactly, and I've had a few people that come in and have very young juvenile, very young cataracts, and this is an important discussion with them because that's, you're taking an eye that has a 30-year-old's ability to change shape, and you give him an 80-year-old's, post-cataract lens, and what? So I mean, it's a big difference in that, but in the sense that you don't need to wait, no. There's no, but that would be the perspective I had. If I had a cataract that was bugging me, I'd take it out in a heartbeat. But not everyone necessarily did that. Yes?
When the video first started playing, did you say ultrasonic energy?
It does. It uses an ultrasound. So basically, you numb the eye topically. My technique is topical. Make a little side port. I open the bag up. So the lens actually comes in a capsular bag. That bag is actually attached to the wall of the eye, 360 degrees, kind of like a trampoline. So you have the lens in the center part, and then you have the springs of the trampoline holding it to the framework. The framework's the eye. So you go in and you open up the top of that bag, you hydrodissect it, squirt a little bit of a special eye solution around, separate that from, then you use an ultrasound to actually basically emulsify. It's called phacoemulsification. Phaco is the Greek for lens. So it emulsifies it. You suck it out through this tiny little aspirator, and then clean up that lens bag, and then put that new lens right inside that same bag. And then that's what actually suspends it in the middle of the eye. Yeah, it's pretty cool. Self-sealing wounds, a triplanars, you go in, up, and in. 3-layer wound, the inflation of the eye itself actually keeps the wound closed. It's, yes, it's cool surgery.
I was one of your early patients.
Indeed.
After you arrived, and I had been wearing plastic lens for 35 years, and you offered correction, not just the cataract, but astigmatism. But after about 3 years, same with my sister and other members of the family, that lens began to cloud, and you blasted a hole in it with laser, and my vision is great. But my question is, why is my vision great looking through a lens with a hole?
It was not the lens actually that I blasted a hole in, and it wasn't the lens that got clouded. It was that bag. So we're organisms. We're alive, and we attempt to heal. So even when we don't want us to heal, we still attempt to heal. So what happened is, it's that capsular bag that new lens went into. Some cells grew across the back of it trying to heal that. And well, those cells all of a sudden started blocking that view again. So I went in and I used a little laser, and it actually broke open the back, and I made a hole in the back of that bag. That bag went down to the bottom of it, and that opened up that passageway, so the light went right back through then. Just a little bit of body's attempt to heal, which we didn't want, and so, in less than 30 seconds, the hole was gone just like that. That's what we call a secondary cataract. Now we don't call it that. Now we call it a posterior capsular opacity, or a PCO. So, yeah. Okie doke. We're trying to get rid of all the eponyms too. You take, so-and-so syndrome, and now it's this 18-word syndrome. You're like, what was that syndrome? What was that one again? Yeah. Okie doke. So I'm going to talk a little bit about something that is actually really exciting for me, because I just got this here. So cataract surgery, the old version of cataract surgery was you waited till the lens was ripe and you had to take it out and blah, blah, blah. It has changed from this ripe lens, wait until you barely can see it all, big surgery, into this really you don't need to wait very much at all surgery, because the risks are so low. The expectations are actually a lot higher too. So a lot of people expect to not need glasses after surgery, which is not always easy to do. You'd be surprised. So the expectations for what you can get out of cataract surgery has become greater and greater. And more importantly, our ability to deliver on that expectation has become better and better and better. So we take measurements of the eye. So we know that the eye is a camera. We know that it's supposed to focus light at this point in time. And so we take a measurement. Well, how much does the cornea bend? How much does the lens bend? How long is the eye? We have all of these formulas that are, third, fourth generation with, 3 million people back analysis with fine tuning and all this, blah, 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 that go into making these third and fourth generation formulas. And they're fantastic, but they're not perfect. And unfortunately, one of the biggest ways that it's not perfect is you're taking out a thick lens, and you put in you can see on that video, you take out a fairly decently thick lens and you put in a skinny little lens right in between it. And there's that potential space that changes what that lens is going to do. I mean, we all remember when we were little kids that we had those magnifying glasses, and you could move it up and down until it came into a sharp point, and we could burn that hole in that, start that little fire on that dry leaf, or as my husband says, burn those ants. No, we never do that. That's the boy-girl version of things, right? So, but when you get it down and right in that right position, you can actually see by moving it up and down that it really changes the effective focusing of that lens power. Same concept in the eye. You move it up and down, it's going to change where that actually focuses the light onto the retina. So this is an important concept, because that's A, one of the things we don't always have a huge amount of control over, and B, a lot of area where we're trying to find what that exact perfect spot is for that. So we have correcting the nearsighted, farsighted, and then we talked about correcting the astigmatism. So we talked about how astigmatism is that irregular shape of the cornea and actually bends light asymmetrically. So the idea we talked about in that astigmatism video is that we can actually put in an astigmatism correcting lens. And it basically is a lens that has an astigmatism amount impregnated into it, and you align it to your anti-axis. So if you have astigmatism this axis, you put the lens in that axis, +1, -1, net result of the retina is 0. That's a concept of astigmatism correction in the astigmatism lens. And it works fantastically, but it can always get better. So this new thing that I'm going to tell you about right now is something called ORA, Optiwave Refractive Analysis. And basically what this does is it takes a whole set of pictures intraoperatively. So you take the lens out, and then you measure the potential of the eye, but it also measures 2 additional pieces of data that we can't measure preoperatively, which has shown to be really important in the accuracy of what our actual outcomes end up being. So it measures another curvature of the cornea, which is the back side of the cornea, which we're now discovering is actually really important. And it also measures where a much better estimate of where that lens is going to sit in the center of the eye. So I'll let this video does much better justice than I do.
The Aura system with Verify Plus technology has been designed for surgeons who demand the most accurate, up-to-date data available. By providing real-time refractive information in the OR, the Aura system with Verify Plus technology helps identify posterior corneal astigmatism and provides additional information that may not have been detected during pre-op analysis. During a cataract procedure, the Aura system with Verify Plus technology provides real-time data in the OR that allows the surgeon to validate and refine his or her surgical plan as needed. This provides continuous assessment of the patient's eye, allowing for highly accurate refractive measurements. Using state-of-the-art laser guidance, a narrow beam of light is directed into the patient's eye and is reflected off the retina. As the reflected light passes back through the optics of the eye, it produces a wavefront image. The Aura system with Verify Plus technology analyzes the wavefront reflected out of the eye by relaying it through an optical system and directing it through a pair of gratings set a specific distance from each other at an offset angle. This creates a fringe pattern, which is captured by a camera and processed using proprietary algorithms to calculate refractive values based on the wavefront image. The Aura system with Verify Plus technology provides streaming refractive information to help determine power, cylindrical magnitude, and axis. Accounts for anterior and posterior corneal astigmatism. Helps surgeons finalize lens choice and placement during surgery. And reduces risk of unexpected residual postoperative astigmatism. Designed to deliver the most comprehensive surgical data in the OR, the Aura system with Verify Plus technology helps you provide more consistent refractive and astigmatic outcomes for your patients.
It really is that cool. It's pretty awesome. I'm really excited about this. This is the 3rd generation. This is the one that's gone viral. So, sorry. This is the 3rd generation and is the one that's gone viral across the country. So this is rapidly becoming something that is standard to offer, and I'm really excited that we are actually, we're solidly in that curve of we're not falling behind. I'm not going to let anyone be a guinea pig, but this is actually a pretty amazing little system here. So, and what it does is it's turning cataract surgery into a LASIK-esque surgery. It's not quite as reliable as LASIK because it hasn't been around. This whole genre of cataract surgery hasn't been around long enough yet to have the back analysis of LASIK. But LASIK is giving about 95% accuracy of hitting our mark. This gives you an 85% accuracy, which is up from 60% before it. So it's a distinct improvement on it. And again, like I said, it's turning cataract surgery into refractive surgery, which we talked about. How does the light rays get bent? They get bent by the cornea bending them and by the lens bending them. How do you change that bend? Well, you can change it in the cornea or you can change it in the lens. So our lens changing technology and the accuracy of that is getting to the same levels as the LASIK levels. And that's something that's really exciting, a huge area of research and development that we'll continue to stay on top of. Okay, glaucoma, yes. No, we stock actually, I stock all the astigmatism correcting lenses. So from 3 to 9. This is that the hospital's actually been really quite impressively receptive to the new technology and the new requirements and the new money and the new stockings. So we basically tripled our stock of lenses so that we have all the stock available, because I need to be able to say, if I go in thinking I'm given, AT7 24.0 diopters and oops, it's actually an AT6 23.5, I need to have everything at my fingertips if I'm going to be able to make those choices. So, and then what it does is that actually we align that astigmatism correcting lens to the appropriate axis, and then we take a picture again to make sure that it's in the correct axis. If it's not, you re-rotate it again. Take a picture until you actually have it absolutely perfect and you know that it's at that correct level. Now, that said, lenses rotate. They have a 5% rotation, so it's never perfect. Unfortunately, nature is never perfect. Medicine is never perfect, but that's pretty darn good. 95% accuracy, or 85% overall and 95% stay in place. These are pretty darn good numbers in medicine. Yes?
Are all of those lenses, including the one that corrects astigmatism, covered by Medicare?
No. No, sadly not. Not yet. Actually, honestly, probably not ever, truthfully. The way Medicare is decreasing their reimbursements and the things they cover rather than increasing them. No, this stuff, unfortunately, a lot of this stuff is, again, it's very similar to LASIK in that this is the premium bonus stuff that you have to pay for. Medicare says you can perfectly fine wearing a pair of glasses. You don't need to worry about anything. They'll almost they'll give you like $150 for a pair of glasses after cataract surgery. The only time they ever pay for glasses. But no, this is not covered.
Financial investment, is there a company that's associated with this?
Yep, this is Alcon. Alcon, A-L-C-O-N. I think this cat's out of the bag. So the investment would have been before Aura was bought. I'm not good enough on keeping up on that. It's an American company. It's out of, actually, I think it's out of San Diego. Either San Diego or Texas. They have a big facility in each of them. And they're the largest company in ophthalmology. They make the lenses and the phaco machine and the Aura, so all those. Nothing else? Okay. So let's move on to glaucoma. So what is glaucoma? So glaucoma is damage to the optic nerve. So again, we talked about where things can go wrong. So let's talk about the optic nerve. Glaucoma is actually not high pressures. Even though everyone thinks of it as just high pressures, it's not. Glaucoma is actually optic nerve damage that is oftentimes associated with high pressures, but not always. 20% of glaucoma is actually normal tension glaucoma, which means you have a pressure of 18 and you're going blind and you have no idea why. So when you go in somewhere and you get your pressure checked, especially, God forbid, if it's a little puff tonometer or someone comes out and does this little pen thing in you, that is not good enough. That is not your glaucoma test. Glaucoma is looking at the optic nerve to determine whether or not there is optic nerve damage in a glaucomatous pattern. So this is really important to understand that it is not a puff test pressure, I'm perfectly fine, nothing to worry about. So glaucoma is where you actually are literally losing those nerve fibers. So back to the model of how vision works. The photoreceptors get changed, they have their configuration changed, they discharge their electric signal to go through the optic nerve. That goes along the nerve fiber. Glaucoma is loss of the nerve fiber. So the signal never gets to the brain. It never actually gets past the eye because you actually lose the nerve fibers. So one important thing is that you have no symptoms of it. Glaucoma is scary. Glaucoma is asymptomatic until the very end of disease. Nobody says, oh yeah, my visual field is going down. Your brain fills in the visual field. You have no symptoms of glaucoma until the very end, and your symptoms are it's dark. People with end-stage glaucoma come in saying, yes, it's really dark in my right eye, and they're completely cupped out. It's irreversible. Once it's gone, there's nothing you can do to get it back. It's progressive. It keeps getting worse and worse and worse. And it's potentially all black blinding. This is different from macular degeneration, which we'll talk about next. This is glaucoma is all black blinding, like actually physically all black. A glaucoma blindness can't even see if light is shined in their eye. Macular degeneration never gets that bad. Glaucoma is scary. This needs to be something that gets evaluated with an evaluation of your optic nerve and pressures, but optic nerve as well as several other different things to look to see if you have any evidence of glaucoma. The incidence of glaucoma increases with age, as unfortunately everything else does too. So why does it increase with age? Is because that drain system in the eye right there, this little drain in this area called the angle, that drain system goes bad with age. It's been used for as many years as you've been alive. And so basically what happens is you get this buildup of these molecules that basically clog the drain. So they get in there, they block the drain, you can't have enough flow going out. This is basic plumbing 101, it's a closed system. You got a faucet, you got a drain. The drain clogs, you're in a closed system, what happens? The pressure goes up. Normal tension glaucoma kind of comes at it from the other way. There's not enough blood perfusion into the eye, and the normal pressure of the eye stops that blood, and that's how that happens. So it comes in a little bit of a different mechanism. The answer to all glaucomas, lower the pressures. So all glaucomas, no matter what the cause is, and I'm not going to hair split the 40 different causes of glaucoma, the answers, I'm going to split into two. The answers for the glaucoma that most of us think about is to lower the pressures. There's one other additional kind of glaucoma that's important to differentiate, and that's closed angles. So you have open angles, which is the majority of glaucoma, especially the primary open angle glaucoma, that it just happens glaucoma. And then there's the closed angle glaucoma. This is a really important thing to differentiate. This is one of the reasons why, especially if you still have your native lens in the eye, you need to be seen by somebody to look at that angle. The incidence of angle closure glaucoma also increases with age. The reason is because that lens, similar to rings of a tree, gets thicker and thicker and thicker and thicker, and it takes up more space and takes up more space and takes up more space, and it actually physically pushes that iris forward and blocks off that angle. So you literally have a mechanical thing blocking off that angle, and that puts you at risk for a really dangerous kind of glaucoma called acute angle closure glaucoma. That's where the pressure goes up to 60 or 80, you're in agonizing pain, you're vomiting, it's horrendous. Oh yeah, when your pressure goes up that high, you're throwing up, you have this horrible headache, your eye is bright, bright, bright red, your cornea turns all white. Extremely difficult to treat in the acute phase, super easy to prevent with a little laser done in the office. So this needs to be evaluated by an ophthalmologist or an optometrist, but someone needs to do something called gonioscopy, where you stick a little lens on the eye and you actually look at the angles to make sure that your angles are open. And that's something that we do on every single new patient. Yes?
How useful is the disc to cup ratio in diagnosing glaucoma?
Extremely useful. That's exactly what we were talking about, where it's an evaluation of the optic nerve. So the optic disc is where all of the nerve fibers go through. The cup is where the nerve fibers aren't. So if you have an increased cup to disc ratio, one can suppose that you've possibly lost some nerve fibers. So it's and that's exactly what we look for when we're also looking at the health, the appearance of that nerve fiber ring. But that's exactly what we're looking for, that cup to disc ratio. And that's why it's so important to not just go in and have your pressure checked. My pressure is 18, I'm fine. Someone needs to look at that cup to disc ratio, because I've seen people come in with a pressure of 18 and a 0.95 cup and end-stage glaucoma. So it's important to have that evaluated. And a one-time pressure check in the eye does not rule out glaucoma. Your pressures in the eyes will go up and down with time, just like blood pressures do. So those are important things to have measured, which is why an annual exam, certainly after the age of 50, is absolutely crucial, because all of these, our body wear out processes, these age-related processes, they all increase, and a lot of them have no symptoms whatsoever and are preventable if caught early, and there's nothing you can do if they're caught too late. So let's take a little bit about how glaucoma is treated. Well, if anyone here has glaucoma, and I know some people here do, the answer is drops, drops, more drops, and then after we're done, let's put some more drops in. So as you all know, taking, that's 9 medications a day, that's really hard. 9 drops a day with 5 minutes between each drop, this is really hard to do. The compliance, the ability to actually get that done, it goes down with the number of drops you get. Let's just be honest. You give me a 4-time-a-day medication to take as a doctor, and I'm going to tell you that's a really tough one. That's a really tough one for me to do. So, and I'm a doctor, and I know all the consequences for it, and it's still hard. So, getting people to actually take their drops, that's hard. I'm not going to complain right now. I don't have any medications, but my mom has her whole host, and she growls every time I tell her to take her drops. So we also have something called a selective laser trabeculoplasty. So basically what that does is, this is actually kind of interesting. We talked about how the proteins actually physically block that drain. So this is a little laser that goes in, and it basically just smacks that tissue and just causes a very little bit of localized inflammation. So that tissue says, what? So you can envision, I always do this in the office, but you can actually see here, if you smack your little arm, you'll actually get a little bit, just tiny little red welts, right? Come in, not a lot, it doesn't cause any damage, but your body just said, what was that? What was that? Came in and said, is there any damage here? So what happens in glaucoma is the body comes in and says, is there any damage? Wow, this stuff is all clogged with junk. And these cells actually eat that junk up and open up the drain system. No permanent damage done. It goes away. I do this every time I have this discussion with people. So the little red welts have always gone away. Doesn't actually cause permanent damage. It's reproducible. It's repeatable. Usually lasts about 5 years. Gives you about 1 drop equivalent. Usually about a 25 to 30% decrease in pressure. For that selective laser trabeculoplasty, when done as a first line. The more drops you add, the first drop you'll get quite a bit out of. The second drop you get less. The third drop you get less. The fourth drop even less. So you'll get the biggest bang for your buck after the first drop or the first laser. So this is where we've got 4 categories of lasers. With exciting news, a 5th category is in FDA trials right now, so it's very exciting. So you have 4 categories of drops. You have the laser, and then we have this whole new category that just has been emerging through the glaucoma world. And these are something called the minimally invasive glaucoma surgeries. We call them MIGS for short. And the idea of this is that all of our maximally invasive surgeries are junk. They work, but they're horrible. They have a super high risk, 50% failure rate in a year. They're annoying to do. They're difficult surgeries. They've got miserable post-op courses. They're horrible surgeries. This is not cataract surgery. The glaucoma surgeries they're lousy. And yet, we have nothing better than the big surgeries. So the trabeculectomies, the tube shunts. So we actually have this whole so we have these high risk, high yield. Like high risk, that's not good. High risk, high yield. So we found a low risk, low yield surgery. We don't have the low risk, high yield surgeries yet. So we're looking for this one, but despite all the things out there, we can't find it. So we have these low risk, low yields. But honestly, they're really, really, really low risk. So the one I'm going to talk about now is the iStent. So there's maybe like 7 or 8, maybe like 4 or 5 different MIG categories. The trabeculotome, the iStent, there's a bunch of different ones out there. The idea with these is that they are low risk, low yield. So this particular one is nice because it's an add-on to cataract surgery. Adds about 2 to 3 minutes to cataract surgery and gives you a drop equivalent with no effort to take a drop. The added risk above that for cataract surgery is practically non-existent. There's really, you're putting in the world's smallest implant and you get a drop out of it for free, essentially. So if anybody has glaucoma, I've started putting this in everybody. There's a little learning curve for being able to get there, but I've long since hit it, and it literally is like a 2-second deal. It's super easy. There's no reason not to do it. It gives you a bit. But it gives you a bit with no added risk.
If your doctor has recommended that you undergo cataract surgery, it is likely that your vision has been a challenge for some time. As a result of this procedure, your cataract will be removed and replaced by an artificial intraocular lens, or IOL. It is also likely that you and your doctor have discussed that you have mild to moderate open-angle glaucoma. This type of glaucoma is most common and occurs when pressure in the eye builds to abnormal levels. This pressure, also referred to as intraocular pressure, may rise when the drainage system in the eye is clogged, which causes an excess of fluid in the eye. High intraocular pressure can potentially lead to permanent vision loss. Unlike cataracts, there is no cure for glaucoma. It is a lifelong disease that must be carefully monitored to limit vision loss, which cannot be regained. Most people take 1, 2, or even 3 glaucoma medications daily to control intraocular pressure. Today, however, a new technology can change how you manage your glaucoma. The FDA-approved iStent implant is the world's smallest medical device. and can be surgically placed into your eye. The iStent device is designed to lower intraocular pressure, and some patients may experience a reduction in their glaucoma medications, but this will be at the discretion of the physician managing your glaucoma. The iStent implant works by improving the eye's natural ability to direct fluid flow through the trabecular meshwork, which is the anatomy through which fluid exits the eye. Most of the fluid in your eye naturally drains through this meshwork and into the bloodstream through a structure called Schlemm's canal. When this outflow system becomes blocked, the pressure in your eye increases. The iStent implant is designed to bypass the blockage within the trabecular meshwork and improve the natural flow of fluid out of the eye. The iStent procedure is minimally invasive and is performed at the same time as the cataract surgery. After implanting the IOL, your doctor will insert the iStent implant through the same incision that was created for your cataract procedure. No additional anesthesia or surgical materials are required for the procedure. The iStent implant is inserted through the trabecular meshwork to create a bypass channel that allows fluid to drain into Schlemm's canal and into the bloodstream. By lowering eye pressure, the iStent implant may reduce your need for glaucoma medications. Ask your doctor today about the iStent implant. It may be a solution to manage your glaucoma and to regain the freedom you deserve.
All right, their graphics in that were beautiful. Their little cartoon. Okay, so that's glaucoma. We're going to go ahead and switch over to macular degeneration. You'll see why I use their videos coming up next as opposed to my animations. So let's talk a little bit about macular degeneration. So we talked a little bit previously about how this is the macula, right? This is the center part of your world, the majority of your vision. The tightest concentration of photoreceptors is in the macula. Unfortunately, this is the place that macular degeneration affects. So the dead center part of the eye. So you can see here the difference between a normal eye and then the macular degeneration, full of drusen and pigment changes. There's a layer underneath the retina called the retinal pigmented epithelium, or RPE. That's where macular degeneration happens. Like, that layer actually is what goes bad, and it creates all these problems. These drusen, these pigment clumps, all of that stuff. That's the regulatory layer of the retina, and that regulatory layer goes bad. Most people here have heard about macular degeneration. Macular degeneration kind of comes in two flavors. It has the dry macular degeneration, which this shows, with all of the drusen, the pigment changes. Once you have macular degeneration, you have the dry, period. Sometimes you get wet on top of that, but it's on top of, not exchanged for, because you always maintain the dry. So dry macular degeneration is macular degeneration that hasn't turned wet. And that's an important distinction, because wet macular degeneration that's the one that people talk about quickly having vision loss and going blind, and that's the majority of the stuff that gets people really scared about macular degeneration. So macular degeneration, again, dry macular degeneration generally has a very slow course. There's not much we can do about it at this point in time. There's tons and tons and tons of research going on to this field, so hopefully there'll be stuff coming out in the next decade or so. Right now we're trying to find something for which the risk of treatment is actually less than the risk of the disease. We haven't actually gotten there yet. So we're looking for something like that. You can't do huge things when the disease is so slow moving, because you'll blind someone long before they would have had problems. Anyways, most people with dry macular degeneration do not go blind. Most people who have macular degeneration do fine. 90% of people who have macular degeneration have the dry kind. Most people in my clinic have the wet kind, because the wet kind is something we actually have interventions for. So wet macular degeneration is basically where blood vessels that are abnormal have grown, developed, they bleed, they leak, you get fluid, you get blood. All of this leads to scarring. Scarring is endgame. There's nothing you can do once a scar is formed. The retina is actually an extension of the brain. It's brain tissue out in the eye. So it scars like brain tissue. We all know that if you get a spinal cord injury with a scar, there's nothing you can do. You can't make it come back yet. Same with a stroke. Once that scar and damage has happened, I can't make it go away. So what we do with macular degeneration is we're trying to prevent that damage from happening. We're trying to treat it before that scar forms so that the scar is a small amount of scar as you can possibly get. So one of the earliest things you can do is use this Amsler grid. So when you have fluid in the eye, imagine putting a drop of fluid on across of a line. All of a sudden, that line becomes wavy and distorted. So we have a grid called an Amsler grid. Dr. Amsler discovered it or designed it. And you can actually see the distortion in the center part of that retina when there's fluid or distortion or damage. You can actually physically see it in that grid. And so this is our at-home, screening that we give all of our macular degeneration patients to make sure that every day they check it to say, whoa, there's something new, and then they come in and see me and we address it from there. So the end stage of dry macular degeneration, which again is the part we don't have very much we can do for, is this. It's called geographic atrophy. It's basically where it's wasted away enough that it's just gone. And this is unfortunate. We don't have very much we can do for this right now. We're working on it, but we don't have very much we can do for it. The good news is it goes really, really slowly, and most people with dry macular degeneration do not end up in endgame geographic atrophy. So how do you treat it? So macular degeneration right now is treated with an Amsler grid for the surveillance to see if they turn into wet, and something called an AREDS2 supplement. So basically, there is an enormous study out there that looked at high-dose antioxidant vitamins. Did they improve the outcomes of macular degeneration? Did they slow the progression or the changeover from dry to wet? The answer was yes. So there was something in it called beta-carotene that was shown to have an increased risk of lung cancer in patients who have a history of smoking. So that was a big issue. Do you do this? Do you do that? What about this lutein and zeaxanthin that people have heard a lot about? So they did a big AREDS2 study. And the AREDS2 study has actually shown that you didn't need the beta-carotene. You could use lutein. The first one, lutein wasn't available yet to exchange out. So now we have AREDS2, which has the lutein, which is good for you. It has all the antioxidants, none of the beta-carotene. Makes it really easy. The answer for every single person, take your AREDS2 supplements. Virtually every company out there has one. Don't smoke, eat a healthy diet, lots of green vegetables, et cetera, and have regular eye exams. So we can do a picture in the back of the eye that allows us on a very microscopic level to look at the retina and see if there's any fluid, any evidence of wet macular degeneration. So wet macular degeneration. So you do all of that, and then you get injections. So I know this sounds horrible and awful, but it's really not that bad. It's really not that bad. For those of you who've had it, it's not that bad. It's not that bad. It looks terrible, and they even made this horrible smoking commercial, making it look absolutely awful. It was horrible. Worst thing ophthalmologists had happen. We were so mad about that. But it's not that bad. It sounds horrible because the whole, cross your heart, hope to die, stick a needle in your eye. Yep, I actually do that all day long. It's what I do. I stick needles in people's eyes. It's not that bad. You numb it. You do it really quickly. It's a teeny tiny needle. The worst part is actually the cleaning stuff that you put on the eye to sterilize the eye to prevent an infection. That's by far the worst part of it. That gives you the irritated red eye for the rest of the day. Otherwise, it's not terrible. Don't be too afraid of it. So there's 3 different medications out there. All of them essentially do the same thing. We have an entire new subcategory of medication that is in research right now that's very exciting. Nothing's coming out quite yet, but there's a ton of research in this. So there's going to be a lot of changes over the next decade in how we treat this, and they're all just going to be getting better. So unfortunately, well, let me give you the fortunate part first. The good news is it works. It works so well that all of the stuff we did beforehand in one day became completely obsolete. It was actually very exciting. It was at my institution when I was there, my second year of residency. The injections came out, they were injected, and poof, the answers. And there's a procedure that I have never even done because it was a 3rd-year procedure. In my 2nd year, it became a plant stand. No one does it anymore. It's called a PDT laser. And not a single person does it because why on earth would you do it when the outcomes are this, the risks are that, and then we went from something that the outcomes are this and the risk is that. So the injections are fantastic. They work brilliantly. This is what happens. So the only bad news is it's not a one-shot deal. It's a multiple-shot deal. So, and here's why. You'll see why it is. I have other videos. So how does the anti-VEGF work? So this pigment layer right down here actually releases a chemical called VEGF, or vascular endothelial growth factor F. So this is, you can see all this. This is supposed to be one nice, pretty, long, flat line. You can see all the lumpy bumpies in here. So all of this stuff and this right here, that's the wet macular degeneration. It's supposed to look more like this, or this is dry because all the lumpy bumpies. This is wet. So you can see the difference. Not good, better. Not good, better. So how does it work? So the RPE releases the VEGF. That's the bad guy. That's the stuff that makes it go bad. So you inject the first dose of anti-VEGF. So it comes in and it neutralizes it. But the problem is the disease process still exists. We can't fix the disease process because it's an underlying aging degeneration. It's an age-related process, hence age-related macular degeneration. It keeps making the VEGF. Now, it does oftentimes go up and down and become quiescent and respond to therapy, and so it's not like it goes on forever and all eternity. But the disease process, we can't fix that underlying process. What we're doing is we're neutralizing the secondary step, which is amazing because the secondary step is actually a common pathway for a ton of different conditions, including diabetes, vein occlusions, all sorts of things in the eyes use that VEGF pathway. So we're actually able to neutralize that pathway, but the disease process keeps making more of it. Thus, we need to keep the injections going. So about every month is what the general guidelines are. Some of them can last a little bit longer, but that's why. So why do we do this? To avoid that. So that's a really good reason to do it. So, and that is, we know that that is the outcome. We know that untreated macular degeneration leads to severe central vision loss. And with it, you can stave that off, that curve of vision loss, the line of vision loss, you can make into, you're still going to lose a little bit, but it's a lot flatter, lasts a lot longer, yes.
Does Medicare pay for that?
Every single one of them. From the $60 Avastins, huh?
Very little.
They almost cover the cost in the med, and then they toss me a nickel for doing the procedure. But, you know, if every single person in the country was treated exactly as they should be for macular degeneration, we would use the entire Medicare budget in the first 6 months. So this is what got the big hoopla of everything, is because those expensive injections are $2,000 a pop. And $2,000 per eye per month, and we have people who are bilateral injections every month. They're VEGF, anti-VEGF dependent. Yes, the good news is that Medicare does cover it, and every bit of it. So what does happen? One of the many things I'm very proud about making happen in this community is we actually now have a low vision center. For the first time at least in Fairbanks, we actually have a vision specialist occupational therapist who is specifically designed. I actually underwrote her education, and she now is available to everybody, covered by Medicare, covered by every insurance out there. It has to be an occupational therapist or an optometrist that are able to do this. So at occupational therapy, you have someone who gives you low vision services, does home visits, helps people deal with life and maximizing their quality of life living with decreased vision. So it's available. Please spread the word. It's not out there enough. It's a service. If I can not lose too much money on that clinic every year, that's fine. There's no income generation for me whatsoever. This is a pure service. And all the goods are sold at cost. There's no markup. This is a service to the community. So let people know that, because it's underutilized, and I can't seem to get the word out that it actually exists and what it can do for people. So if you can help with that.
Does it work out of your office?
It does. She works out of my office, but she also does home visits. So yes.
Can people get other ophthalmologists or optometrists to make a referral to?
Absolutely, and you don't even need that. You call my office and you say you want a low vision clinic, done. It has to pop through an optometrist to be able to get you have to have the right diagnostic codes. There are certain criteria you have to, excuse me, so we have to work the coding system to get insurance to pay for it, but this is what we do. We know how to do that. So, but you don't need a referral, you don't need anything. You say, I heard there's a low vision clinic, my vision is poor, done, enough said. So it goes in, enough said. So like I said, this is a service to the community. I'm going to work and try and see if I can get some community grants to be able to offer people some stipends for the purchase of some of the low vision aids and whatnot. But I'm not 501c3 for this, so I have to route it through somebody else. Details on that. But it's at cost. Everything is 100% at cost. Okay, so now open up to the other 8 zillion possibilities for why you don't see, to see if anybody, I mean, this is just a small handful of things out there for reasons why people don't see. So if anybody has any specific questions on any specific conditions, yes? Floaters, yes. So floaters, we talked about the vitreous, that jelly, that big cavity in the back of the eye. Floaters is basically debris in that cavity. So unfortunately, there's not much we can do for floaters. The important thing about floaters, and why if you have new onset floaters, you need to be seen straight away, is because sometimes those floaters are signs of a retinal tear. Retinal tears can lead to retinal detachments. So that jelly that fills the back of the eye, that vitreous, that's actually remnants. That's left over from the formation of the front part of the eye. When the eye was being formed in utero, the blood vessels came from the optic nerve, where the blood supply is, all the way, it came up through the center part of that eye, formed that whole front part of the eye, the lens, the iris, the cornea, all of that. The lens has a little bit of blood vessels now, but the cornea has no blood vessels, the lens has no, so all of that stuff was formed by that hyaloid artery, and then the whole thing regressed right on back and just disappeared. So that vitreous is the scaffolding, very adherent to the retina until we get older. My 6-year-old, that's like Jell-O. So that stuff, you shake it, it kind of shakes like that, it's solid. My mom, it's kind of like marmalade, kind of swashes around a little bit. So as that marmalade squashes around a little bit, eventually it will pop off that retina and no longer be adherent to that retina. When that pop off happens, that's when you can have retinal tears. That's the most common cause of retinal detachments. When it pops off, sometimes if it tears, you'll get blood, you get floaters that way. The jelly, if it doesn't tear, can also condense a little bit, and those condensations look like little pieces of fruit in that marmalade. And so you can actually see those shadows. So that's what floaters are. And we don't really have very much we can do with them. As your eye is marmalade, that jelly is kind of liquidy. Eventually they sink down to the bottom because they're heavier, they're condensations. Time is measured more in years than in months. So patience, name them. They look like countries. So, yeah. Some really, really, really annoying ones. I should give a caveat. There's a fairly risky laser that does exist out there that has never become mainstream because it's too risky, the risk-benefit ratio. There are a few people across the country that do it, but nobody mainstream does it. Yes?
What is an optic migraine?
Oh, a retinal migraine. Optic nerve migraine, retinal migraine, usually retinal migraine. Basically, it's similar to a migraine with aura. So, people that see auras, you get those stimulations, and you can see like these weird patterns. And so basically what it's doing is it's stimulating the nerves from, inherent to the nerve more. There's a lot of thought. We don't know exactly how that happens. I can tell you what it looks like. And there's nothing really to worry about. This is a really important distinction on visual phenomenon. You have the positive visual phenomenon, which are retinal migraines, central optic tract migraines. Those are really exciting. You get colors and shapes and movements and geographic, triangles, zigzags, little squares, lightning stripes. It was purple and green, and it moved from here and across the eye, and it's very interesting and exciting. I've actually had one myself, which was, again, a lot more, sympathy rather than empathy, right? So super interesting. So you can see all sorts of weird movements and colors. So anytime there's colors, movement, shapes, formed shapes, those are positive phenomenon. Those tend to be retinal migraines, enjoy the ride, interesting. And really nothing to worry about. Doesn't cause problems. Negative phenomenons. Things turn dark, they get gray, you lose vision, things are black. People classically called the curtain. I've only had one person ever came in saying, yeah, it was like a curtain came down. I'm like, oh my gosh, she read the textbook. No one else ever read the textbook. So, but when things turn dark, gray, shadows, dim, that's negative phenomenons. Danger. Negative phenomenons are usually vascular in origin, lack of blood supply to the retina, amaurosis fugax, TIAs of the retina. Those are really important distinction between the positive phenomenons, which you can just enjoy the pretty colors and show. Negative phenomenons, come see me immediately. Yes?
Can you use the stents for narrow angles?
No, you cannot. But narrow angles are actually a much easier phenomenon to treat, or I should say phenomenon, a much easier anatomic variant to treat. You can just do a laser. I mean, literally, it's just like that. It's super duper easy. Once you're then open from that, if you then get a secondary open angle glaucoma on top of the narrow angles, that you can treat with an eye stent. Chronic angle closure glaucoma, which is one of the other things. In addition to acute angle closure, you can get chronic angle closure. It's basically, it gets stuck there so long that it literally grows into it. And actually just glue stuck to it because it's been adherent for so long. That chronic angle closure glaucoma, you can't use the stent for. Yes?
Excuse me, what material is that stent made of?
I believe titanium. It's surgical grade. So similar to a lot of the other implants that go in the body, non-magnetic, no risk for MRIs.
On the list up there, you have diabetes.
Mm-hmm.
What is that?
Wow, that's a huge topic. I'll give you the quick version of it. Diabetes is a major, major cause of vision loss in the United States. Basically, diabetes causes damage on a capillary level. The microvasculature actually gets physically damaged by the high sugar concentrations. Essentially crystallizes, destroys the little itty-bitty blood supply. There's only one place in the body you can actually look in and see the blood vessels. I can look in and see the capillaries. I can do a dye test where I inject a dye into your veins and I take pictures and I literally see the capillary beds of your body and I can physically see where the damage is to that retina. So it causes those blood vessels to pop, to bleed. Eventually it causes areas of the retina that just are dead and dying. Those areas actually will, through a same process with the vascular endothelial growth factor, that VEGF, sends out VEGF and says, hey, we need more blood supply over here. And so the body tries to come and make this blood supply. It makes these new blood vessels to try and help the retina, but it doesn't work. They're horrible blood vessels. They bleed, they regress, they cause tractional bands, all sorts of horrible things happen to it. The blood vessels also, that eventually will absolutely lead to blindness, like hands down, no question whatsoever. Once you start that new blood vessel growth pathway, it is a straight line down to painful blindness, not just blindness, but painful blindness. This is why that annual diabetic exam, even just screening exam when you have no problem at all, is crucial because there's a lot you can do if you catch it at a good enough stage. I can do a lot to get people back up into the safe zone, but if you go down that line, painful blindness, eye in a bottle because it hurts so much, and it's blind. So that's one mechanism, which is the new blood vessel growth diabetic disease. The other version is macular edema, which is basically the blood vessels become so leaky, so it basically turns from a garden hose into a soaker hose. So it doesn't have enough integrity of the vessels to keep the liquid in, so the liquid just oozes out into the tissue around it. And similar to macular degeneration, you have liquid in the tissue so you can't see because you're looking through water. Again, those injections are actually incredibly effective at treating that. So thanks to the macular degeneration research, we now have extrapolated this into multiple other different fields, including diabetes, which is one of the hugest indications that came out a few years back and has revolutionized, again, the way we treat macular degeneration. Diabetes. Now we treat these with injections. Yes?
A side effect sometimes listed for various medications is blurry vision. One time I took over-the-counter cough syrup, the vision was blurry for an hour. What's happening there?
And what did you take?
An over-the-counter cough syrup had something beginning with a D in it.
Dexamethasone. Yeah.
The vision was blurry for an hour, so
It's probably dexamethorphan. Mechanism for that making you blurry. Honestly, truthfully, blurry vision, fatigue, nausea, headache, These are going to be on everything. So they're on everything. They're also incidentally on placebo. So, sugar will give you, a sugar pill makes you blurry vision, the whole 9 yards. All of those, they're very subjective. I mean, I drink a glass of water, and let me tell you, I'm fatigued, absolutely. Oh, wait, I have 2 small children in a career. Okay, might not be related. There's so much. I mean, some of the mechanisms for the dextromethorphan, I can't actually think of why that would give you transient blurry vision. Some of them, the real ones that you need to worry about on those lists of the over-the-counter stuff are the ones that say at risk for glaucoma. So what those are is that's actually looking at putting you at risk for that angle closure glaucoma because it mid-dilates your pupil, and that's when people go into acute angle closure. So if you're ever concerned, ever wondered, ever worried, make sure you get a gonioscopy. Not everybody in town does gonioscopy. So everybody who is seen in my office will have a gonioscopy done. I pan gonia every single new patient and every patient who has a lens every single year. Yeah, so at least once a year. But most people do not check gonioscopy. So that's what's that checking. And in my clinic, you either are fine or you have a laser. Like there's no in between. You're either fine or you have a laser. If you're not fine, I just put a laser in. So but that's actually probably the biggest over-the-counter medication list. I can't, blurry vision is so hard because it's, the differential diagnosis for blurry vision is like 3 volumes about that thick. Yes?
What's happening in the eye to make you say you have blurry vision?
Any of a number of different things. Honestly, the most common of that transient blurry vision, and actually probably dextromethorphan, what this is doing is it is drying you out. Or maybe it was guanfacine. Yeah, I think it was in the cough syrup is dextromethorphan, but I could be wrong. I haven't checked those out in a long time. But a lot of times what can happen is actually, and a lot of the over-the-counter medications have stuff that will dry your eyes out. They actually specifically are designed to dry things out, including your tear film. And the first thing that the light ray hits is actually your tear film. It's not your cornea, it hits your tear film. And so if you have a really irregular tear film, it will make that cornea, the light doesn't pass through anymore. It hits all that irregularities and it scatters it. So dry eye is actually a cause of blurry vision, especially transient blurry vision. So when you can, do one of these things and blink it away and it clears up, that's usually surface disease or dry eye. And it's epidemic up here. I mean, we live in the Arctic tundra. So, dry. And of course, unfortunately, women postmenopausal, oh man, we're so reliant on those hormones and they take them away from us and everything all gets all messed up. So, unfortunately, women up here, we got 2 strikes against us, and then we go in the Arctic tundra. And of course, dry eye worsens with age as well, doesn't everything? So yeah, dry eye is epidemic up here. So probably that transient vision loss that goes away with short periods of time is probably more likely dry eye.
Can you repeat the website that we can revisit this presentation?
I actually don't know. I'm going to give a shameless plug in a second, though, and then we'll be done. Shameless plug for my upcoming fundraiser for global blindness. The Bike for Sight event is coming up on Saturday, July 30th. It's 10 a.m. leaving from my office. It's actually going to be an amazingly wonderful time, even if you don't ride your bike. And even if you have no interest whatsoever of even showing up but want to do something good for the world, you can also register. For every registered rider, whether you ride or not, but for every registered rider, we will be guaranteeing a cataract surgery performed in the developing nation. And I personally, in my clinic, we are going to match you 1-to-1. So for every registered rider, I will personally donate an additional $25 on that. So it's going to be an awesome project. We had 144 people registered last year. It was a fabulous day. We've got lunch, beer tasting from Hootoo's, coffee in the morning. So come out, spread the word, let people know, and every single dollar, every dollar is going directly to global blindness prevention.
Maybe we can make Healthy Living Lecture T-shirt.
There you go.
Members, and then we can all show up together.
And that's bikeforsight.org on that.